So actually, the cataract surgery, as you all know, that this is not an emergency surgery. So why to actually want to do the cataract surgery in the few 2 to 3 minutes? So in the developing country like us, the large population of large populations where the unmet need of the cataract surgery is very high. So the 9 to 12 million people are blind, and 50 to 80% are due to the cataract. And every year, 3.8 million people actually the added for the cataract surgery. So why this region we demand a slightly cost-effective and fast and reliable method? When you are working in the high volume center, you want slightly fast surgery. So now I am going to talk about this is my unedited video, view video. So as you see, in our hospital, they are the actually the waiting area where they are the many camps and where they are the many patients are waiting for the surgery. In and winter season, sometimes the 2,000 people are the admitted for the surgery. So the volume is there, no problem. So initially I make a side port and then put the visco. So I just deepen the chamber. So after that we tighten the bridal suture and make a conjunctival peritomy. It is about 6 to 7 mm. And then hold the tenon with conjunctiva and make a France of incision. And after that, with the help of the crescent, and it advanced into the cornea, make a small side pocket because this is the cataract is not hard. So after that, with the help of the 3.2 keratome, cut in inward direction up to the side pocket. And then with the help of the atrata forceps, used to make a capsular axis after putting the some amount of the visco. And the hydrodissection is done with the help of the hydrocannula. Sometimes the cataract is very soft, so you can just prolapse the nucleus in the antechamber with the help of the hydrocannula. And then put the visco over and behind the nucleus and deliver with the irrigating bacteria. And then cortical removal done with the Simcoe. The remaining part of the cortical matters I always remove from the side port. And then oil implantation done under the hydro. So we keep the Simcoe cannula in the side port and leading haptic in the bag and then dial with the Sinskey hook. So this surgery is completed less than 2 minutes. So actually how to develop this skill safe SICS in 2 minutes? Because we have the very training protocol is very good and we have the 26 modular theater and very good actually the bat lab in our hospital. So we have the 3-year program. In the first year, actually we actually do the how to make a tunnel in every step. And then after the sometimes, surgeon will follow the same steps. So this is the few steps like I make a side port first and then conjunctival peritomy and after that incision. So just adjustment of this steps. So you can do the surgery slightly fast. This is not a one day actually practice. This is required more time to actually practice like that. But this is our hospital, this is slightly need to do the surgery slightly fast. So in the chances of the extension in this high, so I actually run before the extension sometimes. But when you are operating the slightly complicated case, it requires the more time. With the same technique actually applied. So the cortical is sometimes the adhere to the PC. You can actually polish with the help of the Simcoe cannula and then put the lens in the hydro. And after that, we putting the some amount of the antibiotics, moxie, and then subconjunctival dexamethasone. And that they automatically the conjunctiva is opposed. So during the training period, every surgeon follow the same protocol. So gradually with the time, surgeon develop this skill to do the cataract surgery fast. In the winter season, we have do about the 8 to 1,000 surgery in a day. Because we have the more senior person and fellows. Thank you so much, sir.
Wonderful, wonderful surgery, Rakesh sir. Sir, one point. Yeah, go ahead, Amulya sir.
We are promoting not to use the brittle suture. Now you are saying use the brittle suture. They will be confused. If you are doing it, do not have an extra advantage except a mask surgery when you are doing. You want a superior incision. We are giving an estimatic steep axis. So much of, if you want to do a quality SICS surgery, I don't think brittle sutures should be advised.
I agree with you, sir. I agree with you. Sometimes we are actually practicing without bridal suture.
Yeah, nice surgery. I think you have to put a disclaimer, sir. This has to be done only by few surgeons and not to be attempted by all. That the statutory warning has to be put in. And another important thing what I noticed is, should we spend a little one more minute on doing the PC polishing? Yes. Because in most of these cases what I saw, there were a little bit of remnants left and there are high chances of PCO. We would also like to know your PCO results in these 2-minute cases. That will definitely give us more and more insights. Yes, so would you advise a little more spending time, especially on the PC polishing? I just
definitely, sir. Definitely, sir. Thank you.
Two more observations. One, in your first case, when you were aspirating the cortical better, there was a stress on the posterior capsule. We could see the folds. So in a hurry, is there any more chance of PCR? Number one. Number two, while doing your second surgery, just after pushing the IOL, you have removed the cortex, but you have not taken care of the subincisional cortex. And you have also not removed the visco from the anterior chamber. You have not, even you should have removed the visco from the posterior, from the backside of the IOL also, but these are my observations.
Actually, I always put the IOL in the hydro. So all visco is removed. I think I did not see in my cases, in a few cases, IOP spikes there.
No, just a moment.
Sir, second case, there was visco in, around.
Could be from the RAKESH stage because he was, this is a very good idea to give the lens in the, by infusion. The second thing, observation in that, to what you said, Srinivas, is look at the size of the RAKESH. So, when you are doing a 7 millimeter, it's a possibility. You can do a 7 millimeter RAKESH. You reach the equator as such. Plus, the RAKESH fuses beyond the PMMA, and that cuts off, the LE cells. And so I would always say, Chitrakoot, they work in a very defined territory, say 5 districts, I think. So they will get, there are no YAG lasers in that place. So they get back everything, and I don't think their YAG laser rates must be more than 10-15%, which is standard with PMMA.
Thank you. Thank you. It is about in the 70% cases, less than 1 or 1. Yeah, in the 70% cases, not 30% cases. Yeah.
I have a question for the ma'am who presented earlier on. Scleral incision and pocket formation, how close you go to the limbus? Because now people are going very, very close to the limbus. It is almost a corneal incision. Almost a corneal incision, number one. Number two, people have stopped doing peritomy and cauterization of the vessels. Straight, they will make an incision, go for the corneal tunnel, enter the chamber and perform the surgery.
Yeah, many people are doing without a conjunctival cut, but if you are doing in a mass, conjunctival peritomy is better, it will cover. And at least you should be 2 mm away from the limbus. It depends on the grade of the nucleus. If your incision size is bigger, little posterior is preferred, and the different incisions like the frown incision or the horizontal near 4 mm and the cuts like blue menthol technique, you can be 1.5 to 2 mm away from the limbus.
Dr.
To
Kimaya?
me, straight incision has all the advantages. What is your experience about that?
Straight incision, again, if the length of the incision is more, it will get a more astigmatism. If the grid of the nucleus is softer, it can be smaller.